I think precision medicine really has changed the landscape of our treatment possibilities. And we have such an exciting area where we can do testing people, we have target therapies. It's really important for their quality of life, because they have a much better quality of life if they have really the target treatment. And I think also you can earn so much lifetime for these patients because you treat them much better, because maybe not everybody, but most of them, if you really have a good target, you can help them to live longer, you catch them earlier, you treat them better, so they have a much better lifespan. I think there are several issues. One of the issues is for sure the reimbursement problem. And, Europe is small and we have very many different countries with very many different regulations. The second thing is, and I will come back to this a little bit later, I think, is education. People have to know what to do. And just writing on a paper from, let's say, urologist, do some NGS testing. Okay, but what kind of test? So they really have to know what they want. Then we, of course, can help them to do and to bring the results they need. But I think this is a major educational and knowledge problem at the very moment. Well, I think it's a very good question. We know it, for example, we have been testing, at the very moment we do testing in very late stage tumors. And I think the landscape is really changing. So people require earlier testing first to earn some time, because if I know already at the beginning what is going on in the patient, so in case of relapse, advancing disease, the patient can be treated immediately with this target therapy. The second thing is, I think that it's really very important, once again, to do education of people, but also maybe do education on a patient-based, so that people know what options they have. Because if they ask for the option, I would like to have this and this test, maybe it would be, this is future music, I know it, but it would be nice, because then people would say, a clinician will say, yes, of course, I can treat. And I think in these kind of settings, we really need the help of laboratories like you, who will help us to set up, gather the people around the table, to find all the participants to work together and to talk together. Well, first of all, I remember the time when multidisciplinary teams were set up, and this was really a big path forward towards the future, because before everybody did a little bit what he or she thought was nice to do. These multidisciplinary teams have the advantage that we have really all different specialties which play a role in the treatment of the patient. And I think with all these discussions and different angles of view, because everybody has his point of view, of course, a pathologist sees maybe things differently than an oncologist, we really reach a very good consensus. And I think at the very moment, the best way to treat patients. Maybe it could still be improved. I guess it still can be improved, but at the very moment, this is the best we can do. Sometimes I do reflex testing, for example, and based on a histological aspect, I say, well, this tumor, I'm sure, has this and this alteration. And normally it always works very well. You need some experience, obviously. You need also to have some knowledge of the literature, obviously. But in these cases, I really can earn very much time, because I know already what is going on before the patient will maybe relapse, before the patient will display progression. And I think this is something, of course, it's important, and I think it's helpful for the clinicians, because maybe some of those cases wouldn't have been tested. And I say, well, I have tested the case, and I know that this and this is going on in the tumor. Well, AI is something which is, of course, coming up. It has come to stay. But at the very moment, I would say we are still navigating a little bit, and we do not know very, very well. I think in prostate, there are some accesses which are pretty interesting, like the digital twin, for example. implant is a little bit more complicated. I think AI will help probably with progression later on, but we'll still need much more data. And I think maybe in 5-10 years, we will be there. At the very moment, I think we still have to work in a little bit more conservative manner. Well, I think, once again, I think it's really a problem of education. As soon as the clinicians know what to do, how to treat, what to ask for, we, of course, we have all the possibilities. And if we do not have, we just try to have them if there's a kind of request, obviously. But I think the problem is really the education, I think, because many people do not know that they can do this and this and this testing, for example. So I think we really have to start there. And as soon as everybody, but this takes, of course, 5-10 years every time until from the very, let's say, big centers where people are educated and know what is coming up, what is going on, it really goes down to everybody. And then I think there's really nothing which will hinder us anymore to do testing and to give target therapies. Yeah, as I said already, probably help us to gather people together, because you have the power to say, well, we would like to invite you to have a discussion, open discussion, a little bit like a tumor board, but with a precise aim saying, well, we would like to talk about, let's say, testing, target therapies, and then you put together a little bit all these specialties and everybody will enlighten his or her point of view, saying, well, we think this would be nice to do, this is important to do, this is feasible, this is not feasible, because sometimes we think it's feasible, but the other will say, no, we cannot because technically it's not possible. So I think if you help us to gather people together, and as you already do very much education, I think this is really very, very helpful.